Hello, everyone. This is Dr. Mickey recording a lecture on Chapter 20. So Chapter 20 discusses the diseases or pharmacology or pathophysiology and pharmacology on the following four diseases that pertains to the nervous system. So it's specifically about the degenerative disease of the nervous system, like Parkinson's disease, Alzheimer's disease, multiple sclerosis, and the ALS, which is the amyotrophic lateral sclerosis, or what's called the Lou Gehrig's disease. Now, Parkinson's disease, which is the degenerative progressive disease, which results from the decrease or the loss of dopamine production synthesis. So there's a significant decline in the ability of the basal ganglia and the corpus striatum cells in the brain to synthesize and produce sufficient amount of dopamine compared to the acetylcholine, because we discussed this in class and we explained that the signs and symptoms and manifestations of the Parkinson's disease usually results in from the imbalance between the dopamine and the acetylcholine balance. So there is the imbalance between the amount of dopamine and the acetylcholine at the GABA junction. So the which results from the degeneration of the nervous or the neurons that supply the dopamine to the striatum in the brain cells. So the severe degeneration of the basal ganglia and the corpus striatum in the brain cells involving the dopaminergic pathways, which lead to the depletion of the dopamine. So the cause of the etiology of the symptoms usually results from the degeneration and destruction of dopamine producing neurons, which is, as we said, this refers to the substantia nigra portion of the brain. The Parkinson's disease in terms of symptoms, first of all, we said that the controlled movement in the absence of any tremors or any rigidity of the muscles or like high muscle tone, any bradykinesia, which is slow movement and slow motion, or any of these symptoms of the Parkinson's disease are going to, explain, later on, that these symptoms usually results from the imbalance between dopamine and acetylcholine. So the controlled movement for the, this figure, which is the top one, refers to the balance between these two chemical neurotransmitters, GA and ACH. Now, for patients with Parkinson's disease, they have an imbalance between the amount of dopamine, which is lower than the amount of acetylcholine. So there is an imbalance between them. So then that's when we anticipate that there is a disturbed movement or there is a tremor, there is the rigidity of the muscles, bradykinesia, and all these symptoms that are associated with the Parkinson's disease, postural disturbances, postural instability, shuffling gait. All these symptoms are associated with the Parkinson's, would result from the imbalance between dopamine and acetylcholine, in which that we have more acetylcholine than the dopamine at the GABA receptor. So that imbalance between dopamine and acetylcholine, we know that the dopaminergic effect or the dopamine effect on the GABA receptor will be, or junction would be, of inhibition. The cholinergic, which is acetylcholine, which will be the excitation. So we have a balance between inhibitory and excitatory activity of both the dopamine and acetylcholine, and that's when we have a balance between them. That's when we have a controlled movement. But when there is an imbalance, we have more excitatory acetylcholine more than the dopaminergic inhibitory. That's when we anticipate the Parkinson's symptoms are what's called Parkinsonian manifestations. And these Parkinsonian manifestations represented by three triad, or it's called that triad symptoms, three main symptoms. There are additional ones, but these are the three main manifestations of Parkinson's disease: tremor at rest, rigidity of the muscle, which is a high muscle tone, and then bradykinesia, which is slowing down in the initiation and execution of movement, difficulties chewing food, swallowing food, speaking, activities of the activities of daily living, ADLs. Also, everything is ambulation, any activity or any kind of motion that will be delayed and slowed down. Postural disturbances, and that's reflected also with the patient's imbalanced gait and staggering gait, and an unsteady gait, and the buffalo hump, or the postural instability. Also, there will be cognitive affective symptoms. The patients often experience other health issues like anxiety, depression, sleep disturbances, dementia, difficulty urinating or urination, which is from the autonomic nervous system disturbances, like difficulty in urination, dysuria. Now, the therapy or drug therapy for Parkinsonism. So before we go to the therapy, also additional manifestations of Parkinsonian symptoms or Parkinsonism, we said resting tremor, like pill rolling kind of activity with the fingers, the bradykinesia. It's like having that broad-based shuffling gait when they walk. Muscular rigidity, which is like a cogwheeling ambulation, or cogwheeling activity. And then the mask-like face, which is the absence of any facial expressions. It's called the Parkinsonian's face, or a mask-like face, or no expression face. Now, for medications, the meds are usually to restore dopamine functions. We can boost the dopamine production, or we can, blocking the acetylcholine. So we would like to have a balance between these two neurotransmitters, dopamine and acetylcholine, and also to avoid any extrapyramidal side effects. The extrapyramidal side effects, the EPS symptoms, usually result from the Parkinson's drugs or medications. So the anti-Parkinson's or anti-Parkinsonism agents or medications, they are given to restore the balance between these dopamine and acetylcholine, right, in the brain. And the drugs are either dopaminergic drugs or cholinergic drugs, anticholinergic drugs. So either we're going to give dopamine to boost the dopamine, or to block acetylcholine. So these two main groups of medications are explained in this figure, in which that you will find that, for example, we have cholinergic neurons and we have the dopaminergic neuron. And this is the postsynaptic neuron. So the first group of meds is going to be like, for example, the dopaminergic group, which is the levodopa group, which is going to be converted into dopamine at the receptor, become a dopamine, and then acetylcholine, in which that we have a group of medications going to block the acetylcholine receptor. So this will be the benztropine, gagentin, for example, gagentin, benztropine. Benztropine is an anticholinergic drug. So it's going to anticholinergic at the acetylcholine receptor, is going to block it, and the levodopa at the dopaminergic receptor is going to activate. In other words, that it will be converted into dopamine, so that will bring that balance between where boosting dopamine and blocking acetylcholine, so that way we can achieve that balance between dopamine and acetylcholine at the postsynaptic neuron. So Two drugs here, therapy, tend to help with symptoms, dopaminergic agents. So we have the levodopa, which is the precursor to dopamine, like the levodopa or L-dopa. Dopamine receptor agents like the propranolol or pramipixole, Ramipex. So these medics, so either we are giving the precursors to dopamine like levodopa, or we are giving the administering the dopamine receptor agent, which is like the pramipixole. So two medications, dopaminergic agents, or two groups of meds, dopaminergic agents, or we are giving drugs to block the cholinergic receptors like the anticholinergic drugs like benztropine, gagentin. So this is the main groups of medications to treat Parkinson's disease. And the symptoms, right here, we have the symptoms of Parkinson's disease: tremors at rest or resting tremors, rigidity of the muscles or rigid body structure from the rigidity of the muscles, and slowness of movement, which is a bradykinesia, and the loss of balance, which is the unsteady gait or staggering gait. And that's the postural disturbances or postural instability. Now, the EPS symptoms that may result from these Parkinson's or Parkinsonism agents, we have symptoms that may, the duration of these symptoms may last for minutes or hours, sometimes days, sometimes days or like weeks or even long term. So like acute dystonic reaction, in which like there is a stiffness in the muscles of the neck, for example, or laryngospasm that may like minutes to hours, may last minutes to hours. So the treatment for that will be benztropine or other anticholinergic drugs. So this pertains to the acute dystonic reaction, for example, or acute dystonia, in which there is like this stiffness of the neck muscle, the long muscle that connects the back with the neck, which is what is called the torticollis. The stiffness of the sternocleidomastoid muscle, which is the torticollis. That's the medical terminology for the stiffness of the sternocleidomastoid muscle, or laryngospasm, oculogyric crisis, and sort of like the which affects the ocular muscles of the eye. However, that this is called acute dystonia or acute dystonic reaction, and that will be intense, like explained better in the and in-depth discussion of this content will be in the mental health psych course. However, that this is this acute dystonia, it may, as we said, it may last for minutes or a few hours, but the treatment for this one will be benztropine. So these symptoms may result from the Parkinsonism treatment. So when you give drugs for Parkinson's, that's the expected manifestation and side effects. So we will offset that with the anticholinergic drug, like benztropine, for example. Same thing. There is a pseudo-Parkinsonism or akathisia or tardive dyskinesia. For example, the pseudo-Parkinsonism and akathisia, you can treat it with benztropine or beta blockers. APS, like tardive dyskinesia, which is a long term, that may last for years. Tardive dyskinesia can be treated to switch to clozapine, drug called clozapine, clozapine, clozapine. An example of the treatment for this tardive dyskinesia, but this medication will be explained in depth in the mental psych course. And this life cycle of the dopamine, and this explains also, this figure explains that, dopamine, administering dopamine intravenously, it's not going to be of any help to patients with Parkinson's disease, because we know that dopamine is going to be rejected right at the blood-brain barrier, so it will not be allowed to pass through the blood-brain barrier as a dopamine. So the best way is that to administer the precursor, the levodopa. The levodopa is the precursor to dopamine, and in the brain is going to be converted in the terminal of the dopaminergic neuron into dopamine. So that way we will have the So that we would have the levodopa being converted to dopamine at the dopaminergic neuron in the brain, and that will result in boosting that dopamine at the dopamine receptor, and that will give that kind of bring that balance between dopamine and acetylcholine to fix the or to treat and mitigate on and uh, intervene as an interventions for the Parkinson's symptoms and to offset these symptoms. In other words, to stop the symptoms. So we have these medications under the dopamine agonist and related drugs. So we have amantadine, Simetrel, the bromocriptine, Orladeal, levodopa, carbidopa, which is Sinemet, levodopa, carbidopa, entacapone, which is Stalevo, and pramipixole, Mirapex, and ropinirole, Requip. Ropinirole, Requip, it's also one of the best drugs or the drug of choice for restless leg syndrome, RLS. Restless leg syndrome, the best treatment for that is ropinirole, Requip. The brand name is Requip. So these are the highlighted ones or localized ones, or the ones that you need to know, or to know that these are the best medications and the most commonly used drugs for Parkinson's disease. Now, before we get to the rest of the medications here, let's go back to the EPS and the neurologic or neuroleptic malignant syndrome as a side effect from the dopaminergic agents. Dopaminergic agents may result in its side effect. It's a serious side effect called the neuroleptic malignant syndrome, NMS. The NMS, it's a life-threatening neurologic disorder, and it's most often caused by an adverse reaction to the neuroleptic or antipsychotic medication, either to neuroleptic disease or antipsychotic drug. The symptoms of the neuroleptic malignant syndrome may include high fever, sweating, unstable blood pressure, muscle rigidity, and autonomic dysfunction. So in most cases, the disorder will, develops within the first 2 weeks of treatment with the drug. However, the disorder may develop anytime during the therapy period. The syndrome can also occur in patients taking the antiparkinson's drugs like the dopaminergic. So patients who take any of these medications, the dopaminergics drugs, or those who may discontinue them abruptly, they may develop the neuroleptic malignant syndrome. The problem with the dopaminergic agents or agonists is that the patients receiving prolonged anti-Parkinson's therapy or pharmacotherapy with these dopaminergic agents, they may periodically experience a loss, the losing the drug effect. So they may experience a loss of drug effect, which is called the wearing off effect. So this wearing off effect, the wear off effect, appears gradually near the end of the dosing interval. So symptoms may worsen at this time because the concentration of the drug has fallen below the therapeutic level. So adjusting the dosing interval um, to provide for more frequent dosing may help to reduce this effect. And we'll talk more about, and we have a few questions also in the case studies or in the other set of PowerPoint slides to discuss the wearing off effect. We have a few questions about that. So wearing off effect, just for brief, that when a patient was being described or experienced the abrupt loss of the effect of the drug of the Parkinson or the dopaminergic agent, in which that they have, which resulted in the off phenomena or the wearing off phenomena, which is usually treated with entacapone, which is the COMT inhibitor. So it's a COMT inhibitor, and the amantadine would be also used to treat dyskinesia. But for wear-off effect, well, we can include the entacapone or the COMT inhibitors. The NUR268 and the COMT, both are enzymes, the MAO-B and the COMT, both are enzymes involved in dopamine breakdown and metabolism. So these two enzymes responsible for the dopamine breakdown and metabolism. So the inhibitors of these enzymes are used in the treatment of Parkinson's disease. So it will prevent the dopamine breakdown and metabolism. So it will boost, eventually boosting that dopamine at the in the brain. Dopamine agonists. So they are described to restore balance of dopamine and acetylcholine. The levodopa, amantadine or sometrol, and the bromocriptine or parlodil. And we have a prototype drug which includes all three components of levodopa, carbidopa, and entacapone in one brand name called Staliva. Contraindications: glaucoma, so the drug restores the neurotransmitter dopamine in the extrapyramidal areas of the brain, so it will relieve some Parkinson's manifestations and symptoms. So especially like the resting tremor or tremor at rest, the bradykinesia, slowing down the motion, so it will improve that. The unsteady gait will be improved. The rigidity of the muscles with the increased tone of the muscle, also that will be improved. That will improve. So to increase its effect, the levodopa is combined with two other medications, carbidopa and entacapone. So including the carbidopa and entacapone, that will prevent the drug breakdown. So the dopamine, it will prevent its enzymatic breakdown. prevent the breakdown of the dopamine by the two receptors. I'm sorry, by the two enzymes we mentioned earlier about the MAO-B and COMT enzymes to prevent the enzymatic breakdown. But several months may be needed to achieve maximum therapeutic effect. So it takes up to several months to achieve the therapeutic effect or the maximum therapeutic effect. So abrupt withdrawal of the drug can result in Parkinson's-like symptoms or the NMS, which is the neuroleptic and malignant syndrome. So cases of hyperpyrexia or high fever, episodes of fever and confusion, it resembles the neuroleptic malignant syndrome. And it has been reported in association with dose reduction or withdrawal, abrupt withdrawal or discontinuation of therapy with carbidopa, levodopa, and entacapone. So patient who had abruptly or suddenly stopped taking the drug or significant reduction of the dose results in the manifestations of a neuroleptic malignant syndrome that we discussed earlier. The adverse effects, side effects of Stalevo include uncontrolled and purposeless movements, like extending the fingers and shrugging the shoulders, involuntary movements, loss of appetite, nausea, vomiting. So the muscle twitching and the spasmodic winking are early signs of toxicity. The orthostatic hypotension is common in some patients. The drug should be discontinued gradually because the abrupt withdrawal can produce acute Parkinson's-like symptoms. So when we stop the drug abruptly, suddenly, that could result in Parkinson-like symptoms. Psychoses may develop in about 20% of patients taking levodopa. And drug therapy with antipsychotic medications such as clozapine or clozaril may be necessary to control the hallucinations and paranoid symptoms. The Stalevo is contraindicated in the treatment of narrow-angle glaucoma. So suspicious pigmented lesions or history of melanoma also should be contraindicated in patients with suspicious pigmented lesions, skin lesions, or a history of melanoma. So drug, also this medication should be avoided in cases of acute psychoses and severe psychoneuroses within 2 weeks of therapy with the MAO inhibitors. This medication should be avoided in cases of acute psychoses and severe psychoneuroses within 2 weeks of therapy with monoamine oxidase inhibitors. Now, interactions. The drug interacts with the Stalevo. It interacts with many drugs. With haloperidol, which is a haldol, and taken concurrently with Stalevo, it may antagonize the therapeutic effect of Stalevo. So the haloperidol may antagonize the therapeutic effect of Stalevo. Methyl-dopa may increase toxicity. Antihypertensive medications or antihypertensive drugs may cause increased hypotensive effect. The anticonvulsant or anti-epileptic drugs may decrease the therapeutic effect of Stalevo. The antacids containing like magnesium, calcium, or sodium bicarbonate, they may increase Stalevo absorption, which could lead to toxicity. Abnormalities in lab tests may include elevation of the LFTs, liver function tests, such as alkaline phosphatase, EST, ELT, lactic dehydrogenase, and bilirubin, and abnormalities in blood urea nitrogen, the BUN, and positive Coombs test have also been reported in patients who take this drug. We explained last week in class the rationale for including or adding the carbidopa to the levodopa, in which that, in the absence of the carbidopa, 98% of the administered dose of the levodopa is completely metabolized in the intestine and the peripheral tissues, so it'll be completely metabolized, and either by the decarboxylase or the COMT enzymes, leading only to 2% of the drug action in the brain. So in order to deliver the 2.5 milligrams of levodopa to the brain, the dose of that levodopa must be large, like 125 milligrams of levodopa to eventually produce that 2 point, or yield to result in 2.5 milligrams of levodopa to reach the brain. So this is only levodopa with carbidopa. However, if we are going to adding the carbidopa to levodopa, so if you include 10 milligrams of the carbidopa to the 25 milligrams of the levodopa, eventually you will reach the same, will yield to the same effect of 125 levodopa alone without carbidopa. So adding this carbidopa to the levodopa is going to protect the levodopa from being metabolized either in the intestine, but mostly in the periphery, by these COMT or MAO enzymes, or MAO-B and COMT enzymes. So that's the rationale for combining the carbidopa and adding that to the levodopa in either in the Cinemet or in the Stalevo tablets. So that we can give a smaller dosage of the levodopa. Instead of giving 125, you are going to administer 25 milligrams of levodopa, and it's still going to result in or yield the same effect of having that 25 levodopa without carbidopa, which is the 2.5 milligrams in the brain. COMT, which is the catechol or methyltransferase inhibitors, the COMT inhibitors. And these medications are the COMT medications, or the medications that end with capon, which is the suffix for all these COMT inhibitors, like entacapone. Other medications, benztropine, Gentin, epinephrine, which is Benadryl, and the Artane, the trihexyphenidyl, the Artane. All these medications also can be treated. These are the anticholinergic drugs. Anticholinergic drugs, which has the anticholinergic activity, and they are also will be used in combination to the dopaminergic agents or dopaminergic drugs in the treatment of patients with Parkinson's disease. So the benztropine, anticholinergics like benztropine or trihexyphenidyl, Artane, two anticholinergics, and very effective to treat patients with Parkinson's disease. So the benztropine acts by blocking the cholinergic receptors. So it will block the excess cholinergic stimulation of the neurons in the corpus striatum. So it's used for the relief of Parkinson's-like symptoms and for treatment of the EPS, extraterminal symptoms brought by the antipsychotic pharmacotherapy. Because the psychotic pharmacology or pharmacotherapy results in what is called the EPS syndrome or symptoms. And then the benztropine is to offset these symptoms or to prevent the symptoms. So this medication suppresses the tremors, but is not effective at relieving the tardive dyskinesia. So it will suppress the tremors, but it's not effective to relieve the tardive dyskinesia. The patient may be unable to self-administer the medication and may need assistance. And we know that this is because of the patient's the disease condition. In terms of the patients with Parkinson's disease, they have the bradykinesia, and they have the difficulty in the initiation and and the execution of the movement, and they have problem with the ADLs, and they have problems with all the different with any activity that because of the muscle stiffness, muscle rigidity, and the slow motion and the unsteady gait, and coordination and the of movement. So they need assistance with with the in terms of unable to self-administer the drugs, so they need assistance with the medication. Given that these meds are benztropine congentin is anticholinergic drug, so we can as we relate this to the chapter 12 content on anticholinergics, we will anticipate that the side effects or effects or adverse effects from anticholinergics like benztropine congentin would be dry mouth, constipation, tachycardia, dilated pupils, mydriasis. So the urinary retention. The adverse general effects include like sedation, drowsiness, dizziness, restlessness, irritability, nervousness, insomnia. Also, will be included as part of the side effects here. Contraindications: neuroanglic glaucoma, MG or myasthenia gravis, blockage of the urinary tract, severe dry mouth, heel hernia, severe constipation, enlarged prostate, like benign prostate hyperplasia, and liver impairment or liver disease. The benztropine interacts with many drugs. So for example, the common medications that should not be used in combination with, for example, the lorazepam, haloperidol, clonazepam, lamotrigine, lisinopril, lithium, metformin, the fluoxetine, and all of these are depressant and antipsychotic medications, starting from the fluoxetine, risperidone, quetiapine, and then we have levothyroxine, which is the thyroid hormone. The over-the-counter medications also OTC or all over-the-counter cold remedies or medicines should be avoided. The drugs that enhance the dopamine release or activate dopamine receptors introduce additive effect. Haloperidol, Haldo, will decreases the effectiveness of the benztropine. The benztropine effect will be decreased if given concurrently administered with haloperidol. The benztropine also should not be taken with alcohol because the combined sedative effect. Severe sedation could result from given benztropine with alcohol. Antihistamines, phenothiazines, tricyclic antidepressants, TCAs, may increase the anticholinergic effect. The treatment of overdose, physostigmine 1 to 2 milligrams sub-Q or IV will reverse the and treat the symptoms of anticholinergic intoxication. So reversal of the symptoms of the anticholinergic intoxication is always, remember that, is going to be managed with physostigmine, either 1 to 2 milligrams sub-Q or IV. Dementia, which is progressive failure of the cerebral functions, not caused by impaired level of consciousness. So that could result from decrease or the dementia will result in a decrease in terms of manifestations, will be a decline in orientation, decline in memory, both short and long-term memory, language, attention, and then alteration or changes in behavior. And that's due to the decline in intellectual ability. So the pathophysiology in terms of etiologies or causes of dementia, it's mainly due to the degeneration, which is due to genetic predisposition, like Alzheimer's disease and Huntington's disease. Progressive dementia produce nerve cells degeneration and the atrophy in the brain cells. Could be from decompression or atherosclerosis or from trauma, other than the degeneration due to the genetic disposition. So the Alzheimer's disease, these are some of the causes or etiological factors that may result in dementia. So Alzheimer's disease is responsible for more than 70% of all different types of dementia. So Alzheimer's disease is the second most common degenerative disease of the central nervous system, and progressive loss, which involves the progressive loss of the brain function, which affects the brain memory, confusion, dementia. So the Alzheimer's disease is responsible for more than 70% of all different types of dementia. And what could be the possible cause of dementia? We mentioned earlier about the genetic predisposition, which accounts for about 10% of cases of that dementia due to genetic factors. Chronic inflammation, the environmental factors, immunologic factors, nutritional viruses or viral infections. So Alzheimer's disease, there are theories that would, explain, why, Alzheimer's disease would happen or what's the pathophysiology of Alzheimer's disease. There is no any specific or like, at least we can say that the exact cause of Alzheimer's disease is unknown. So there is some mutations that for the encoding amyloid precursor protein or alterations in the apolipoprotein type E and loss of neurotransmitter stimulation of the choline acetyltransferase. These are some of the theories that will explain the changes in the brain that result in Alzheimer's disease and associated symptoms of the Alzheimer's disease. Two main things that we found in the autopsies of patients who've been diagnosed with Alzheimer's disease, that there is a neurofibrillary tangles. So the neurofibrillary tangles, which are the proteins in the neurons in the brain, they become distorted and twisted. So it's kind of distortion and twisting of the proteins in the neurons of the brain cells. There is also another change they found or revealed from the autopsy, of the uh, of patients diagnosed with Alzheimer's disease, which is called senile plaques, which is the areas of degeneration that reveals. So the two main alterations in Alzheimer's disease, or in terms of the pathophysiological changes, substantial changes in the pathophysiology, neurofibrillary tangles, which is the proteins in the brain or neurons, the brain become distorted and twisted, and the other one is the senile plaques, in which that the areas of the area of degeneration, um, the reveals plaque-like material. The plaque is like a deposition, the plaque formation, like in cardiovascular system. Also, we'll find that in atherosclerosis, there will be like plaque formation, and like in the coronary arteries, for example, the plaque is deposition of the lipids and other substances. So this one is senile plaques. Senile means related to the aging process. Senile. So that's the plaque deposition and the plaque-like material in the brain. So um, for example, we have here the B, which is the um, sorry, with A, we have the neurotic plaque here. So the senile plaques, again, that's the areas of degeneration, which reveals the plaque-like material, which this material is going to disrupt the nerve impulse transmission in the brain cells. So the nerve impulse transmission will be delayed, disrupted due to this senile plaques, that plaque-like material, um, in which they're going to revealed as the areas of degeneration in the brain cells. So the structure of damage, or the structural damage in the brain, will consist of the amyloid plaques, which is senile plaques, and the neurofibrillary tangles. Two main changes. Now, the changes found during the autopsies of the brain of deceased with the diagnosed previously with Alzheimer's disease. The structural changes will cause a loss in number and functions of the neurons, and the symptoms result from progressive damage to the neurons and the brain. Now, the clinical manifestations will include the patient become forgetful, and there are stages of their Alzheimer's disease. In terms of the pathophysiology, we'll have like stages of Alzheimer's disease as disease progresses to the last stage. From like becoming mild, moderate to become like severe, the symptoms become very severe. Now, the clinical manifestations will include like forgetfulness, emotional upset, disorientation, um, become very confused, and lack of concentration. There is a decline in abstract thinking. The problem-solving ability is also declines. Judgment will be also affected, severely affected. Impaired memory and judgment, um, confusion and disorientation, inability to recognize family and friends, aggressive behavior to some extent, or some of the stages or late stages become very aggressive and combative. So that aggressive behavior will be one of the most devastating symptoms or manifestations of patients with Alzheimer's disease later on during the disease process. Depression, psychosis, and that would include like paranoia and delusions, and anxiety as well. The diagnosis is usually, we can say that, it's made by to rule out other causes of dementia. So we have to rule out all other causes of dementia, and eventually we'll say that the patient is being diagnosed with dementia or Alzheimer dementia. And the only confirmatory diagnosis or testing or diagnostic study would be after death, which is the autopsy of the deceased patient. When they do the autopsy, they will find that these changes in the brain, like amyloid plaques and neurofibrillary tangles in the brain. So goals of pharmacotherapy for Alzheimer's disease. It's not meant, the pharmacotherapy for Alzheimer's is not to treat the disease itself in terms of treatment of the disease or the syndrome, but to slow the memory loss, slow down the progression of the disease process, to improve patients of ADLs, um, uh, slow down the dementia symptoms, improving the behavior, improving patients' cognition and ability to problem solve and ability to for judgment, for the abstract thinking, the lack of concentration. It can to some extent be improved, not that much, but at least there is some improvement in these. So again, the hallmark of the treatment here is to slow down of the progression of the disease process. So there is no cure for this disease. The cholinesterase inhibitors, which is these are the drugs to prevent the breakdown of acetylcholine. So it will enhance the transmission in cholinergic neurons. It will slow progression of Alzheimer's disease, and drugs or agents would be donepezil, like Aricept, the Residine, Exelon. The more acetylcholine means more memories. So that's why we have to increase the acetylcholine, enhance acetylcholine at the cholinergic receptors or neurons. Less acetylcholine, less memories. So the donepezil or Aricept, which is the prototype drug for the Alzheimer disease, or the drugs for Alzheimer's disease, they will prevent breakdown of acetylcholine, so they will enhance the transmission in the neurons, so they will slow down the progression of the disease process. So it may result in side effects like nausea, vomiting, and dizziness, headache, but less likely or less commonly revealed side effects. But the most important is the GI, which is nausea and vomiting. The drug is, or donepezil, the Aricept, it's an ACE inhibitor. It's a acetylcholine enzyme inhibitor. So it inhibits the acetylcholine enzyme responsible for the metabolism or destruction of the acetylcholine. So it will improve the memory in cases of mild to moderate Alzheimer disease or Alzheimer dementia, because it will enhance the effect of acetylcholine. Because we said more acetylcholine, more memory, less acetylcholine, less memory. And that is the effect centrally in the cerebral cortex. We can increase the acetylcholine effect in the neurons in the cerebral cortex that has not or have not been damaged. Patients should receive pharmacotherapy for at least 6 months prior to assessing the maximum benefits of drug therapy. Now, the improvement in memory may be observed as early as 1 to 4 weeks following the medication. Improvement in memory may be observed, so do not anticipate that the memory improvement will be revealed and or result in within less than a week. It may take as early as 1 up to 4 weeks following medications since the start of the medication, when we anticipate an improvement in memory to be observed or to be set and present in the patient's behavior, and patient's memory will improve. It takes about at least 1 up to 4 weeks after the initiation or the starting the medication. So the therapeutic effect of the donepezil are often short-lived, and the degree of improvement is modest at best. The advantage of donepezil over the other drugs, because we have other medications in the same group, but the advantage of this donepezil Aricept over other drugs in from this class is that its long half-life has a long half-life, which would permit to be given once daily. So instead of giving the drug twice or 3 times daily, we can just give it once daily. This is one of the advantage of this donepezil or Aricept is that it has a long half-life that would allow us to give the drug only once daily. The common side effects of donepezil are said the main ones are vomiting and diarrhea, and less common we have other side effects like the um, uh, fainting or dark urine. The central nervous system effects like insomnia, syncope, depression, headache, irritability. The musculoskeletal side effects may include the cramping of the muscle cramps, bone fractures, generalized side effects like headache, fatigue, chest pain, increased libido, flashes, urinary incontinence because um, of the cholinergic effect, dehydration, and blurred vision. So it's contraindicated. Aricept is contraindicated in patients with GI bleeding and jaundice. Um, the donepezil will cause anticholinergic to be less effective because the drug is going to result in cholinergic effect. So it interacts with several other drugs, like, for example, the botanical. Botanical causes synergistic effect. The phenobarbital, phenytoin, dexamethasone, which is steroid, rifampin, which is an anti-TB drug. All of these may speed the elimination of donepezil, so which results in decreasing the drug effect, and the patient will be subtherapeutic with the amount of drug left in the body. So because the donepezil can action or acts by increasing the cholinergic effects, so 2 cholinergic drugs should not be given or administered at the same time concurrently. Treatment of overdose, the anticholinergics such as atropine may be given for the overdose as an antidote for donepezil overdose. Memantine or Namenda, another cholinesterase inhibitor like the donepezil or Aricept, very similar to that. Multiple sclerosis, which is the inflammatory disorder caused or causing damage to myelin sheath in the brain and spinal cord. It's progressive, results in progressive weakness and visual changes and disturbances. Cognitive deficit will result from this disease as well. Etiology is unknown, but we have risk factors for the for possible causes and risk factors like genetic, microbial, microscopic pathogens. So the multiple sclerosis, which is the MS, which is debilitating autoimmune condition that involves progressive and irreversible demyelination of the brain. So this myelin sheath is going to be completely destroyed progressively. So we have a myelin sheath and progressively will be destroyed. So the speed of the impulse, of the nerve impulse, will be severely affected by the destruction of this myelin sheath. So that's why first of all, it's an autoimmune condition, and it involves the progressive and irreversible demyelination of the brain and spinal cord and cranial nerve and neurons. So this myelin sheath on the brain, the neurons, the spinal cord neurons, and the cranial nerve neurons, that will result in inflammatory process and then the destruction of this myelin sheath. So this damage to the myelin sheath occurs in diffuse patches throughout the nervous system and slows or stops the nerve impulses. It slows down the nerve impulse. At some point, it will block it or stop the nerve impulse. So as the disease progresses, the brain's cortex become atrophied, like smaller, and there will be scar tissue, like plaque formation, will develop throughout the white matter of the brain cells. So the progression of this damage varies from person to person. There is no one clinical picture of one MS patient or like an MS scenario. It's very individualized and it varies. This damage varies from one person to another person. So as we believe that this, that this is an autoimmune disorder, so the underlying cause of the MS is still unknown. The course of the multiple sclerosis is also unpredictable. Some patients will have a mild course of symptoms with little to no disability. They will still be able to function with no apparent disability, whereas others will experience steady deterioration with increasing disability. So there is no one clinical picture of this disease. The clinical manifestations of MS vary to a large extent depending on the degree of damage and a specific nerve affected. So it depends on how many nerves affected, the extent of nerve being affected in the brain. So the clinical manifestations of MS, again, it vary depending on the degree of damage and the specific nerves affected. However, the disease is typically characterized by remissions and exacerbation. Like other chronic diseases, patients at some point will be exhibiting or showing or revealing very minimal symptoms or no symptoms of the disease process of the disease. At some point or other days, will be interested in having like attenuating, extenuating, and will having heightened symptoms of the disease. So this is called remission, no symptoms or mild symptoms, to exacerbation, which is heightened and very severe symptoms. So the exacerbations may last for days to months, like fever, hot bath, the sun exposure, stress. All these are considered as triggers or may worsen these episodes. Fever, hot bath, sun exposure to the sun, stress, all of these may trigger or worsen these episodes of the exacerbation of the disease process. Although that the remissions and exacerbations are common in almost all patients, but the disease may continue to progress in some patients or individuals without remissions. So continue to be like exacerbation all the way towards the end. So the multiple sclerosis was said initially the myelin sheath of the neurons and brain, spinal cord, cerebrum, and spinal cord and cranial nerve neurons are going to be destroyed or lost or damaged, but the nerve fiber is not affected. So it's all about the myelin sheath. So myelin can regenerate and symptoms disappear, resulting in remission. And again, we explained the difference between remission and exacerbation. So again, the MS, it's an autoimmune inflammatory disease affecting the myelin sheath of the CNS, and it's characterized by focal demyelination of the plaques that occur at different times and locations within the CNS. So it typically affects the optic nerves, the white matter in the brain stem, spinal cord, and usually it's generally seen in younger women more than males. The incidence always increase with latitude of birth and is twice as high in patients of the northern European descent as those of the African descent. The clinical manifestations, the symptoms, in addition to the focal abnormalities, patients often suffer from chronic fatigue. So neuropathic pain, spasticity, impaired cognitive ability, all these are known symptoms or manifestations of the MS. The symptoms may be exacerbated by heat and exercise. Or infections like UTIs, upper respiratory tract infection, or or urinary tract infections, or URTIs, which is urinary upper respiratory tract infections. So renal or respiratory infections. So the MS in a younger or young patient presented with any of the following, we have to consider the MS. For example, a young patient coming or presented with subacute loss of vision, double vision when looking to one side, which is diplopia, electrical sensation running down the spine when the neck is flexed, the subacute spinal cord symptoms like paresthesias, like a numbness, bowel bladder dysfunction, or the worsening of the neurologic symptoms with heat or exercise. These are like warning signs or things that to consider that they could be an MS in a young patient presented with these symptoms. So the management of patients with MS, it depends on that acute flares of the MS. So first of all, diagnosis of the MS will be based on the MRI with or without contrast, CSF fluid testing with a spinal tap. But the management of the MS, it will be first treated with the acute flares, the acute flare-ups with high doses of IV glucocorticoid, like solumidrol or steroid, to treat the acute attacks. but do not slow disease progression. This is just for acute attacks. There are different patterns of the disease process, like relapsing, remitting, progressive, or so we're not going, over these 4 different types of MS patterns. But the treatment for the MS, one of the best treatments is the Copaxone, for example, widely used drug. So the first group, before we get to the Copaxone, we have the interferon beta 1, and we have interferon beta 1A or B. The 1A, which is Avonex, or the 1B, which is the beta-seron. And then we have the Latiramir, which is the Copaxone, very common drug for MS. This is for the less aggressive disease. So the options would be injectable interferons like the Avonex, the beta-seron, or the Copaxone, known as the ABC drugs, which is A, Avonex, B, beta-seron, and then the C, which is Copaxone. We have other medications. If the patient is opposed to injections, there are other medications that can be given. And these drugs have been shown to decrease the frequency and severity of the relapses in patients with relapsing remitting MS. But these are the 3 most important medications that can, we can just consider for the MS treatment. So the immune modulating drugs. These are the disease modifying drugs used to treat or for treatment of the relapse, remitting multiple sclerosis and secondary progressive multiple sclerosis. Again, we said there are 4 different types of multiple sclerosis, and the immune modulating drugs that are very effective for the relapse remitting one and the secondary progressive MS. Relapse remitting MS and the secondary progressive MS. So the interferon beta, we said Avonex or beta-seron, either A or B, beta 1 or the beta 1 or beta 1A or 1B, Avonex or beta-seron, and then we have the Copaxone, the Latiramir. So it's a synthetic protein that will simulate the myelin basic protein, so it will protect at least the myelin sheath, and it will slow down the progression of the disease process. So it will reduce symptoms and decrease lesions. The immunosuppressants also can be considered for the treatment of the MS. So the immunosuppressant, it will or used for progressive forms of the MS, or the primary use would be for MS patients who have not responded to the immune modulating therapy. So if you put the patient on, Avonex or Avonex or Bereseron or Copaxone, and they are not responsive to this therapy, which is immune modulating therapy, then you can put them on the immunosuppressants, considering that they are not responding to the immune modulating therapy. And the last disease here from this group of the neuromuscular junction disorders, we have the ALS, which is amyotrophic lateral sclerosis, ALS, or what's called Lou Gehrig's disease. And we, went over this briefly in class, that the disease is a progressive degenerative disease characterized by both affecting the upper motor neuron and the lower motor neuron. And it was just in brief description of the more upper or lower motor neurons that first of all, the MS, multiple sclerosis, is a disease of the upper motor neuron found in the central nervous system, which both affects the motor and sensor neurons. So it's upper motor neuron. That's the MS. However, the ALS affects both upper and lower motor neurons. So when thinking about the motor system, let's see what is the upper motor neuron, or what are the symptoms of the upper motor neuron disease. When we think about the motor system, it is important to understand the difference between the upper and lower motor neuron. The upper motor neuron originate in the central nervous system. These motor neurons send tracts down to the spinal cord, where the synapse, where they synapse with the lower motor neuron. So the loss of the upper motor neuron control will result in or cause weakness, loss of voluntary movement, and an increase in muscle tone. So this pertains to the upper motor neuron. However, the lower motor neuron, it originates in the spinal cord and is responsible for the transmission of motor information. Responsible for the transmission of motor information from the spinal cord to the involved muscle group. So remember, the upper motor neuron synapses with the lower motor neuron, and all motor impulses then are transmitted over the lower motor neuron to the muscle. Now, the lower motor neuron is considered to be the final common pathway. If there is a disease of the lower motor neuron, if any disease involves the lower motor neuron, then the patient will be presented with weakness or paralysis, atrophy of the muscle, and loss of the DTRs, which is deep tendon reflexes. So the upper motor neuron, again, presented with weakness, loss of voluntary movement, and increase in muscle tone. Lower motor neuron, weakness or paralysis, atrophy, and loss of deep tendon reflexes. But again, recap that the MS is the disease of the upper motor neuron. However, the ALS, it's a disease of both, characterized by both upper motor neuron and lower motor neuron. So a patient would have signs of both arising in the brainstem and then in the anterior horn of the spinal cord. So what's unique, so the key facts about the disease is that the hallmark of the ALS is the combination of the both upper and lower motor neuron signs and symptoms. So in a patient with generalized weakness, muscle or tongue fasciculations, which like contractions, or hyperreflexia, atrophy of the hand muscles, normal ocular muscles, we will consider ALS. And that point, we should request some diagnostic testing like EMG for diagnose patient with ALS. So the unique feature of this ALS is that there is this tearing of the ocular muscles that will be normal. Normal ocular muscles will not be affected. Preservation of bowel and bladder function also will not be affected. Normal sensory, absence of pain. Also, the cognitive impairment, it may not be apparent, might be in the late stage of the disease process, but usually patient will be cognitively intact. So in suspected ALS, the LP lumbar puncture or spinal tap may be necessary to exclude infections and the inflammatory myelopathies, like West Nile virus or paraneoplastic disease, and cervical spine MRI may be necessary to exclude cervical spondylosis. So this has to do with, pertains to the diagnostic testing. So the patient, when they are presented with like dysphagia, nasal speech, like as if they are speaking from their nose, it's called nasal speech, head drop from weakness of the neck extensors, shortness of breath, muscle twitching, which is called muscle fasciculation, muscle twitching, muscle cramps, progressive generalized weakness, normal eye muscles or ocular muscles, normal bowel and bladder function, which is really typically is going to be preserved. That could be like, symptoms to consider for, to diagnose patient with ALS or to consider ALS. We went over the upper motor neuron signs, and we said that, with the upper motor neuron signs will be like spasticity, increased muscle tone, hyperreflexia. And lower motor neuron will be atrophy, especially of the tongue and muscle of the hands, fasciculations, which muscle twitching and weakness of the muscles. So the management would be the main drug, or one of the only drug I would say for the ALS is riluzole, which presumed glutamate antagonist. That's the only FDA-approved drug to treat patients with ALS. It improves survival by approximately 3 to 6 months. So riluzole comes as a tablet and suspension liquid form to be taken by mouth. It's usually also taken on an empty stomach, like an hour before or 2 hours after meals, twice a day, every 12 hours. The riluzole, it may slow the progression of the ALS, but doesn't cure the disease. And this concludes the lecture.